A warm welcome to Governance Now. This is Gitanjali Minhas and you're watching Checks and Balances. India's medical inflation is estimated to be 14% annually, considerably higher than the general inflation rate. Healthcare costs outpace wages, causing financial hardships to India's huge population. A Niti Aayog report says that around 7% of India's population, which is around 10 crore people, are annually pushed into poverty and economic distress due to healthcare spending. High out-of-pocket expenses pushes low-income families to seek medical help. They have to sell their assets or seek loans to pay their medical bills. Health is now being viewed as a commodity, both in its national health policy as well as Sustainable Development Goals of 2030. India has committed to universal health coverage by 2030. However, gaps remain in its implementation and equity, outpatient coverage, financing, and drug access. Speaking on the issue are a group of medical and health experts. Professor K.Srinath Reddy is the Chancellor, Public Health Foundation of India, University of Public Health Sciences, and Chair, Center for Universal Health Assurance, Indian School of Public Policy.
As per the World Health Organization, as well as the World Bank, countries should be spending anywhere between 5 to 6% of their GDP on health, and also ensure that out-of-pocket expenditure incurred by individuals or families is less than 20% of the total health expenditure. Now, in our case, neither of them is true. Our total health expenditure itself is about 3.8%, and our government health expenditure is 1.84% of that. And as per the government calculations, the out-of-pocket expenditure is about 1.51%. However, if you look at current health expenditure, which actually reflects the way people are subjected to financial hardship for the services that they are currently seeking, household spending is about 54%, which means that while the government has certainly ramped up its public financing, much of that is going into infrastructure and expansion of medical colleges and setting up of some of the surveillance systems, which are all very important, but they pay their dividend in the medium to long term. But the ordinary citizen is feeling the pinch today in terms of the services that he or she is seeking for very essential health needs and is having to pay for. We do claim now that our out-of-pocket expenditure has come down quite substantially in the recent years, that we have now reached about 39.4%, whereas we used to be horrendously closer to 70% about 2.5 decades ago. However, much of this reduction is because the public financing is going towards setting up of infrastructure like medical colleges, surveillance systems, and so on. That's good, but we also need to spend on services. The NSSO surveys of 2001 and 2011 showed that still 7% of the Indian people were being pushed into poverty each year because of unaffordable healthcare expenditure, which means we need a lot more spent on services. And if we do not do that, then we may actually come up with a slightly spurious estimate of financial protection by estimating only out-of-pocket expenditure without looking at service coverage. We need to look at both. And our service coverage is still close to about 70%. We need to increase it to over 90%.
National Co-convenor of Jan Swasthya Abhiyan, Indranil, says that globally, public spending on health is a major driving force, and India too needs to expand its spending on public health, as seen during COVID.
Sri Lanka spends 3 times than India in terms of per capita public spending. Thailand, Malaysia spend 10 times more. You compare China, Brazil, they spend 14 times more. In comparable income group, our public spending is the lowest. States like Bihar, UP, Chhattisgarh, Jharkhand, Madhya Pradesh, where majority of poor, vulnerable population live, Assam, their public spending is much lower compared to some of the sub-Saharan African countries or even lower. Overall, there is some increase in public spending on health. It is coming to 1.4% of GDP or so, but it is much less compared to all other countries. Coming to out-of-pocket expenditure, I wanted to also share this anguish with you. We recently looked at various data sources to see that share of out-of-pocket in health is increasing. Households are spending more. We have a system of national health accounts where we try to capture all the sources of money and try to see how much is the out-of-pocket spending. In 2017-18, when the last big household health survey happened, it showed that now people are reporting less ailment, people are not able to seek hospital care. Nothing can be more distressful than this. The NHA numbers are showing is a decline in out-of-pocket expenditure. This is far from reality in the country. Look at the price rise of medicine. Significant rise, more than 10% price is rising every year. Our out-of-pocket burden is largely caused by outpatient expenditure. If 100 rupees is spent on health, more than half comes from people's pocket, which is the highest in the world. We have non-communicable disease on the rise. So elderly people who need regular medication every day, so that kind of medicines are getting costlier.
Dr. Nagaraj Huilgol is a senior cancer specialist in Mumbai. He says with half of India's population paying high out-of-pocket expenditure, the numbers are high. He cautions against euphoria around insurance and overemphasis on privatization of healthcare.
So there's no perfect healthcare system anywhere in the world. Having said that, we were on a right track when we were started with the public healthcare. And if you look at the Niti Aayog, have started actively encouraging private sector over public sector. Probably in a country like ours, it's not such a great idea to emphasize so much solely on our private sector and the government of India abdicating its responsibility towards the poor. Out-of-pocket expenses seems to have gone down, but it's 48% of the people pay out of pocket. And one of the recent statistics shows that nearly 43 billion people went down because they had to pay the exorbitant healthcare fees. 43 million is not a small number. Any percentage in India, because of our population is so huge, translates into a huge absolute number. Most of the people who have an insurance, 1 lakh, 2 lakhs, 5 lakhs, and that burnt with 2 or 3 days or 4 days. So you end up paying a lot more money. Everyone keeps talking about PPP. I'm very convinced that in PPP, it's the private who gets benefited and not the public. Best example is PMJ Yojana. They have certain budget, but I don't think that's the answer. There are a lot of corruption there, a lot of inefficiencies there. CGHS is pathetic on board. Most big corporate hospitals don't like. I think now they have made it compulsory for the private hospitals to have CGHS. So look at the comparison. The consultation of CGH, government pays you 300 rupees, wherein you are making few thousand rupees per consultation. Where the comparison? As a result of which the doctors keep avoiding them. Unless you are in Delhi, wherein you are very, very influential secretary, joint secretary, etc. And even the government servants face a lot of problems. 5 to 10% of the people maybe can afford premier corporate healthcare, but outside of those 10%, if we need to address the healthcare concerns of these people, I think overemphasis on a private sector is not the way to go.
Agreeing on the failure of various health insurance schemes to address the needs of healthcare, Dr. Abhishek Bhargav, consulting physician at Nanavati Max Hospital in Mumbai, calls for strong regulation by the government.
If you look at any insurance coverage, half of things are excluded from insurances. Some of them are hidden in such great words that whenever patients get admitted, and we see that on a regular basis, they face a lot of trouble in terms of getting insurance. Policies are just sold off for the sake of, because of kickbacks involved in between. Of course, an initiative in terms of Ayushman Health and all is worthwhile, but even though it has been launched, there is no hospital that actually accepts an Ayushman Health card. At least in metro metro cities, no tertiary hospital accepts an Ayushman card. So today's time, 3 to 5 lakhs is nothing. Specifically, if you're staying in metro cities where the cost of living is so high, say suppose you have to undergo a bypass, it's going to cost you more. Everyone is not going to go to the general ward and get a bypass done. Even a basic bypass is not covered in 3 lakhs. If you're diagnosed with cancer, medications are so expensive, newer generation medicines, and you'll be surprised, immunotherapy is not covered by insurance companies. No insurance company covers immunotherapy. What do you do for a stage 4 cancer? And to make matters worse, even when they have insurance, the insurance company does not cover medications. So it is quite unfair that this all has to be looked into. The government should step in and, regulate everything.
Not only has privatization cannibalized nursing homes and charitable hospitals, there's a decline of 20% nursing homes run by doctors or a group of doctors. There's an oversupply in urban areas and people have to depend on big hospitals with deep pockets. The Clinical Establishment Act has not been ratified by most states and there's complete disregard to regulation of price control. Along with rising health insurance premiums, rejection of claims is also increasing. According to stakeholders, as much as 42.5% commission is paid by reputed insurance companies to the agents, not just to sell policies, but also to get claims rejected. Importantly, insurance only covers hospitalization and does not include non-communicable diseases, OPD consultations and diagnosis, causing a huge financial drain to those seeking healthcare. In effect, privatization has failed to fill the gap in remote areas of the country.
Large sums of public money is being handed over. Insurance scheme, government funded insurance scheme, the Prime Minister's Jan Arogya Yojana, the state schemes. Essentially, tax money being handed over to private sector to give care. The claim is that earlier poor people couldn't afford to go to private sector. They had to resort to poor quality public system. So you give money to the private sector so that they give free care to patients. Latest rounds of National Sample Survey data shows that overwhelming majority of those who are benefiting out of the scheme are non-poor. If you are a poor person, you cannot afford to go to a private sector. You go to a public hospital, you pay around 3,000-4,000 rupees for hospitalization. Now you have been given this card with the assurance that if you go to private, you will get free care. On an average, they are paying 14,000 to 15,000 rupees per hospitalization. So they are resorting to public sector and relatively better off are getting benefit of the huge subsidy that you are giving to the private sector. This points out that what is needed is to strengthen the public system. Cancer is the other extreme where medicine prices are so high that most of the insurance is not able to cater to cancer. You need a package of 10-15 lakh, which is unaffordable to most citizens of the country, most people. The market-based solutions are really failing, both private sector, the insurance, government subsidy to private care. Since 2017, the National Health Policy, healthcare is being seen more as a industry, which can be a major source of revenue. Now, there are major problems with that understanding. We are not saying that no private sector. Globally, there is a strong regulation of the kind of profits you can make, the prices you can charge, the quality you need to adhere to. We are privatizing various medical colleges, district hospitals across the country. Part of Jan Swasthya Abhiyan, we are resisting. Government has the capacity to build system and it should do rather than handing over. If you look at, say, experience of UK or even in other developing countries, privatization of public service has not actually led to desirable results. Many countries who had earlier privatized are going back to remunicipalization of public service. In India also we have Jharkhand, in Maharashtra, in Karnataka, we built movements to resist privatization because they were becoming very exclusionary.
In 2000, 100% foreign direct investment was allowed. With the liberalization, now, a lot of people have crept into that 10%. So the absolute number of this is huge. There's a lot of cheap money there, as they say, with the venture capitalists, and then I call that as a vulture capitalist corporatization corporatization has made this illness into a business, into a commodity, and the rules of engagement now have changed. Premise here is not the welfare of the patient. The moment you are listed on the stock exchange, your responsibility is to your shareholders. You're not responsible for your patient care. The whole paradigm, it's a commodity to be bought and sold, and hence you need to make profits for your investors and your shareholders. The way we look at illness has changed. It's not service. Doctors, the investors, the healthcare paraphernalia is now all about making your company profitable so that investors can come and put in more money. The whole corporate hospital is designed to satiate the vanity of the affluents. It's not just about getting better or getting treated. Of course, there are some good sides to it. I'm not saying there are no good sides to it. The good sides could be because there's so much money, you have the latest equipment, latest infrastructure, and of course they're all predominantly in metropolitan cities. So we are talking of a very small segment of this country, which is being served by the vanity hospitals, because you are paying for the perfumed air and the marble floor. So overheads are so much more. But what happens is this also with the upper middle class people, that becomes aspirational. They would like to be treated or to be seen treated in these corporate hospitals than going to the nursing home next door.
More worrying is that with the corporatization also coming in the financialization. Entities who are located across the world, say BlackRock, financial firms who make major financial investment are now heavily investing on healthcare in India. And this virtually shifts the control of healthcare delivery out of the country. Both corporatization and financialization is pushing the frontline people, the doctors, the nurses, to induce unnecessary care to patients. It's becoming exclusionary to a great extent.
Present-day healthcare is driven by the nexus between pharmaceuticals, the insurance agents, and the venture capitalists. These three decide how to go about it, how to treat, who gets the insurance, who doesn't get the insurance.
Patients who get admitted with high-grade fevers, the insurance claims get rejected. Insurance companies would look at trivial excuses of something which is absolutely unrelated and they would reject insurance. All denials should be specifically audited by a third party. Government should ensure that everyone is covered and covered adequately for adequate protection. Even the OPD consults, like how it is in the Western countries, should get covered as part of insurance. I once had an 85-year-old gentleman who was paying his insurance for the last 30 years, got admitted in the middle of the night at 2:30 with chest pain. His ECG had subtle changes. By morning, his blood pressure had dropped down. He was on BP-enhancing medication. And that day morning, when his claim was put in, the insurance company rejected that admission was not required. We lost that gentleman the next day. One needs to wheel in the insurance companies because in times of stress, it's the insurance company which lifts the hand.
While the Pradhan Mantri Jan Arogya Yojana is expanding, about 30 to 40% of the population is a missing middle, which means it is not covered either by the government or privately purchased health insurance. Between the states, metropolitan and rural areas, there are enormous disparities in service coverage. Also, large parts of rural population lacks awareness on health insurance, and amongst those who are covered by government insurance, literacy is low. This reduces their ability to access benefits and service coverage.
Ideally, we should move towards what's called a single payer system, in which all publicly funded and even privately purchased health insurance schemes are brought under one large pool. It increases the risk pool and therefore the cross-subsidization between the healthy and the sick at any given point in time is high, and therefore you can also increase the benefit package. Secondly, you ought to be ensuring portability from one place in India to another place in India. The PMJ assures that, but many of the state health insurance schemes are restricted to their state. But we should also move towards a capitation system, like an integrated care. What you pay for a pooled set of services, which may extend from primary care to tertiary care per person. There you have standard management guidelines and technical audits performed. so that you can also check that, so that rationing of care doesn't take place. You cannot have primary care functioning in a silo, secondary care functioning in a silo, tertiary care functioning in a silo. You need to have integration between primary, secondary, and tertiary care, which also means that we need better equipped, better staffed primary healthcare systems. We have a rural health mission, but at the national level, you don't have a coordinated national urban health mission yet. You need to have very good regulatory systems across agencies, across all states, periodic recertification of their capabilities. Insurance companies also ought to really observe certain ethical code of conduct, not do cherry picking while getting consumers registered for the insurance and ensuring that past illness is not unfavorably regarded. I think the Insurance Regulatory and Development Authority of India is doing a good job. I think we need to do a lot more.
When earlier there were general practitioners, family medicine is going extinct now. Fresh medical graduates do not want to go to non-urban or rural areas, preferring to get absorbed by corporate hospitals with good salaries and required infrastructure, irrespective of the pressures to generate revenues.
If you are entering a bank, any kind of organization, you ultimately have to perform incentives, annual appraisals and everything. It's very, very similar in corporate hospitals also. So ultimately everyone has to perform. Everyone is looking at a good life. I mean, isn't the doctor entitled for a good life? When the hospitals are definitely looking at the doctors generating more revenue for the hospital. It does tend to put in pressure on the doctors, specifically on junior doctors.
Underinvestment in health results in lack of required infrastructure like human resources, medicine supplies, diagnostics, etc., etc. Health experts said that in primary healthcare, there are 80% vacancies across categories of medical officers like pediatricians, gynecologists, radiologists, nurses, etc., etc., where only 2 positions are filled for 10 vacancies. Frontline workers like Ashas are paid minimum wages.
Across the country, we need to increase public financing of health, both in central and state budgets. About 2/3 of the health expenditure comes from the states. They should also ramp up their budgets to more than 8% of their annual budget. In recent years, if you add the Ayush complement to the allopathic doctors, we have reached a reasonably respectable figure of 1:834, as opposed to WHO recommendation of 1:1000. However, we have very serious interstate disparities. For example, Goa has 1 doctor for 353 persons. Tamil Nadu has 1 doctor for persons. Kerala has 1 for 509. And on the other hand, Bihar has 1 for 28,400. UP has 1 for 2,400. So there are huge disparities. And again, all the resources we have in society, whether public, private, or voluntary, whether allopathic or Indian systems of medicine, we need to bring all of them together into one framework. That framework needs to be well thought out, because the Ayush practitioners mostly urban aggregated. Secondly, those who are posted in rural areas in the primary healthcare centers or even in the sub-centers, they are not provided the Ayurvedic medicines. Standard management guidelines are important. Equally important, we need to train people in family medicine as a postgraduate discipline after graduation. The young doctor after internship is seldom fully qualified to be thrown into a rural environment and left alone without the necessary skills and knowledge. What you have to do is to create national health service of some kind under the national health mission. Say, okay, for short-term postings, short service engagements of 3 years or 5 years, we are ready to enlist you, but you'll have to be ready to serve in the states wherever we post you. You'll get crash course in language like IAS officers and others do, but you will have to serve there. And you'll be rewarded with special priority for postgraduate admissions. Give them incentives. Ensure that the hospitals are well equipped, know the stockouts of drugs and essential equipment, and there are good governance systems and good cadre management practices. Predictable transfer and postings policy, not because some MLA or a minister decides somebody should be posted, or some doctor has established a presence in private practice in that area and doesn't want to move to another area.
State like Rajasthan or Tamil Nadu, because they could provide free medicine, diagnostics better, or Kerala. People are depending on public system. What is needed is better decentralization and accountability of village health and sanitation committee or Rogi Kalyan Samitis at the facility level. They are all dysfunctional. There is no accountability of the health system in their decision making, in the implementation, and that lack of accountability is multiplied in the private sector. There in Swasthya, we have people who are part of the consumer fighting cases. The way private sector make it difficult to get justice. Overall, there is a governance and accountability failure in the system. Swasthya, very simple demands. Increase public spending to 3.5% of GDP. Union government, which currently spends 0.3% of GDP, should spend 1%. States who are spending 1% or so should spend 2.5%.
Referral fee cut practice, overcharging, unnecessary procedures, prescribing expensive medicines to patients where less expensive medicines can work, keeping patients longer in intensive care than required are some of the malpractices in private settings.
Corporatization has almost legitimized referral fees. There was some case study I was looking at the other day. One of the companies were claiming income tax exemption or some kind of tax exemption for the referral fees. The court said, no, you can't do that. So you can imagine how rampant is the referral fees. And that adversely affects the young doctors. So they have to end up in a corporate hospital as a foot soldier. This is dire state of affairs as of today. There is no proof this kind of a privatization has improved any indices. There have not been studies that just because you're spending more money, you're getting a better outcome. No, there's
India ranks third globally in terms of pharmaceutical drugs by volume. Drug regulation in India is controlled under the Drug and Cosmetic Act of 1940 and Rules 1945 in a fragmented drug market with a shared responsibility between the central CDSCO and state drug regulatory authorities, leading to poor coordination and enforcement, fake and contaminated drugs, and profit-driven practices.
Of the total medicine sold in the market, only 18% of medicines are under price control. So, vast majority of medicines, which are spurious, combination drugs, drugs which are non-essential, but they're out of price. So, we need greater control of pricing, particularly branded medicines like cancer medicines. India was the first country in the world who said we'll have compulsory licensing. If we find that one medicine is too costly, it is patented, Indian company would produce an alternative much cheaper. But due to industry pressure and all of that, particularly big pharma, we have given up on this. Without compulsory licensing, the kind of distress that people are facing today due to cancer will not be able to solve.
The law is there, but implementation is absent. You need to have laws which are equitable to all and are practically possible to implement. Acts have to be uniform. They should not offer undue advantage to anyone. The Clinical Establishment Act basically mentions that you need to prescribe generic drugs. As a doctor, you prescribe generic drugs. But who decides X brand has to be given or Y brand has to be given? It passes the onus to the chemist. So the chemist makes money, on whichever strip or whichever medicine the chemist has a better margin, he will sell that. There are certain substandard companies which come in with the XYZ molecules. At times they're not even DGCA approved, DGI approved, sorry. There should be a third party auditing of all these pharma companies. You need a legislation strong enough to ensure that bogus drugs are not being manufactured and not being sold off in the name of a branded medicine.
There was a time when there was a big debate as to whether doctors should run the pharmacy or not. But now the institutions do it on the behalf of the doctors. Or doctors, there are ways and means of it. That means, when the patient comes to you, he's a captive, if not a prisoner. So these people go and bargain get a huge margin, 70%, 80% margin, and sell it at MRP. That's a big scandal. I was to long back. This CEO said, we made a terrible mistake. So we kept the MRP low to compete in the market and we're regretting it. I cannot sell my medicine to most of these pharmacies because if your MRP is low, your margins, even if you give the same margin, the money that the doctor or the company or the hospital or the corporate will make is so much lesser. As a result, they would a similar molecule with a higher MRP. And if you look at most of these corporate hospitals, they insist, especially for the inpatient, they buy the medicines from their own pharmacies. But so there is a Supreme Court order that patients have the right to buy medicines from wherever they want to. But see, these are all legitimate corporate practices. Referral fee, there is a huge battery of marketing people, and this is all, corporatization has almost legitimized referral fees.
70% of the clinical decisions are based on diagnostic reports. When a doctor has asked for 2 tests, the patient comes back with 150 tests offered by the lab at attractive rates. With around 3 lakh diagnostic labs across the countries and the numbers growing, diagnostic sector also is under-regulated and fragmented.
There has to be a legislation to govern these. These labs should be audited, and data that they're collecting, multiple tests being done. No one would, in their good senses, be doing 150 tests in a price of 10 tests. So obviously, whatever information they are collecting, it must be used for some research purposes or some other purposes, or the information may be making money by selling of that information.
We need very clear standard management guidelines both for diagnostic procedures as well as therapeutic procedures. The Indian Council of Medical Research is developing such guidelines. Apart from financial audits, you need to have technical audits, at least of a sample of the cases everywhere, that insurance companies often do. You also need to have a social audit of the patients and the families. Now for the National Rural Health Mission, for the primary care component, they actually have common review missions. But that's only for the government, and that's mainly for primary care services. But we don't have regular reviews of what's happening across the board in the private sector as well. Pooled public procurement is a very important element, because when you look at drugs and diagnostics, that is where maximum amount of immediate impact is there in terms of pushing people into poverty. A rule of thumb is about 60 to 70% of all healthcare expenditure is in the outpatient, and about 60% of that is on drugs. So if you can provide drugs free of cost in government facilities, at least the essential drugs free of cost, then you are immediately able to provide a lot of financial protection to a lot of people in the country. And even the private sector can be regulated that way. Essentially, all hospitals which are now accredited to government-funded health insurance schemes and are deriving financial benefits from that should be made also to purchase from a pooled public procurement agency. I mean, Tamil Nadu has a pooled public procurement system. Other states also should emulate it. The Tata Memorial Hospital has established a national cancer grid. It has more than 200 hospitals participating in it. And they have shown how, by actually bringing together some of the hospitals to negotiate for some very important but expensive cancer drugs, they were able to procure drugs median reduction of 86% in cancer drugs. So if they can do it and they can demonstrate it across both public and private hospitals, why should that system not be followed? Hospitals, even in the private, can form consortia. The consortia can actually use their power to get drugs, equipment and supplies at a cheaper rate, but with quality assurance. These are the kind of reforms that can be brought about so you can pass on the benefit for the poor patient.
Economist and Nobel laureate Kenneth Arrow said that education and particularly health are examples of market failure due to asymmetry of information between the provider and the consumer. And therefore, there is a need for public policy intervention and the government must step in. Thank you for watching Checks and Balances.